Hello and welcome. This is a video on ESR and CRP by Dr. Ignatius Cole. We have heard a lot about ESR and CRP even during our clinical practices, and even in every in the blood test we send for patients. We always do ESR and CRP. But what exactly are they, and in which condition they are raised? Let's find out. And which one is more important? We'll find. All right. First of all, these are acute phase reactants and are observed in inflammation. The reference range for CRP is less than 10 mg per liter, and the ESR is for adult males is less than 10 millimeter per hour, and for adult females is less than 20 millimeter per hour. And this reference is from the Davidson Textbook of Medicine, 23rd edition. So, laboratory investigations we usually do with inflammation are leukocytosis, increased platelet count. CRP is the most widely used laboratory investigation in inflammation. There is other acute phase reactants like fibrinogen, ferritin, complement components, which are all raised. There is a reduced albumin level, especially in case of severe inflammation, and normocytic normochromic anemia occurs in chronic inflammation as anemia of chronic diseases. So what is CRP? A C-reactive protein is full form is, and it is an acute phase reactant synthesized by the liver. It opsonizes invading pathogens. When I learned about opsonins are basically, opsonization means like the pathogens are made tasty by attaching CRP to it. So there is a pathogen, so the macrophage doesn't recognize it, but when CRP is attached, the pathogen looks tasty, macrophage recognizes, and macrophage will phagocytose it. So the CRP level rises within 6 hours of an inflammatory stimulus, and it may rise up to 1,000 folds. It is a direct index of plasma inflammation, and its half-life is 19 hours. It is a sequential measurements of CRP can actually monitor a chronic disease or an inflammatory disease. A disease with active inflammation but with normal CRP are SLE, systemic lupus erythematosus, systemic sclerosis, ulcerative colitis, and leukemia. However, intercurrent infection in these conditions may provoke a significant CRP. ESR. ESR is an indirect measure of inflammation, unlike CRP, which is direct measure. And ESR measures how fast erythrocytes fall through anticoagulated blood. Erythrocytes are inherently negatively charged. So the red blood cells are inherently negative charged, but plasma proteins neutralize the surface charge of erythrocytes. So erythrocytes are negatively charged, so they repel each other. Negative repels negative, like repels like. So erythrocytes repel each other, but when plasma proteins neutralize their surface charge and make it more positive, then their inherent repulsive forces are overcome and they form a relix, they form a tight knit formation, and any condition thus that increases or causes an increase in these plasma proteins, whether it be monoclonal or polyclonal, like there is an increase in serum immunoglobulins, which will increase the ESR. But CRP is not increased because there is no inflammation, but there is increase in plasma proteins. So inappropriately low ESR occurs in hepatocytosis and sickle cell anemia because the cells are unable to form Rulex despite the presence of inflammation because of the abnormal shape of the red blood cells in hepatocytosis RBCs as SPSF, and in sickle cell anemia is sickle cell. So comparing ESR to CRP. CRP is actually quite simple, sensitive, early indicator of the acute phase response. It is also a direct indicator, so it is used in preference to ESR, that is CRP is preferred. If both are used, discrepancies should be resolved by assessing the individual determinants of ESR. So the ESR is affected by a multitude of factors, so this should be found out like full blood clotted blood film to rule out any hepatocytosis or sickle cell anemia, serum immunoglobulins, because plasma proteins increase or immunoglobulin increase can cause increased ESR, and protein electrophoresis. IgE is very low in plasma, so it does not contribute significantly to ESR. So conditions with abnormal CRP and or ESR can be as follows. We'll go into them one by one. Acute bacterial, fungal or viral infection, necrotizing bacterial infection, acute inflammatory diseases, chronic bacterial or fungal infection, SLE, Sjogren's syndrome, multiple myeloma, pregnancy, old age. So in acute bacterial, fungal or viral infection, CRP is increased at the range of 50 to 150 mg per liter, or it may be even more than 300 mg per liter. ESR is increased. In case of necrotizing bacterial infection, CRP is vastly increased, more than 300 mg per liter, and ESR is also increased. In case of acute inflammatory diseases like Crohn's disease or polymyalgia rheumatica, also CRP is increased, like in the range of 50 to 150 mg per liter. ESR is increased. In chronic bacterial fungal infection like localized abscess, bacterial endocarditis, or tuberculosis, there is an acute and chronic inflammatory response. There is also increase in acute phase proteins with polyclonal increase in immunoglobulins. Thus, because there is increase in immunoglobulins, ESR is increased disproportionately to CRP. That means ESR is increased more than the CRP level. And in case of SLE and Sjogren syndrome also, there is a chronic inflammatory response. There is increased acute phase proteins with polyclonal increase in immunoglobulins. The CRP is paradoxically normal in these cases, but the ESR. In multiple myeloma, there is monoclonal increase in immunoglobulin. There are formation of myeloma protein without acute inflammation, so CRP is obviously normal, and ESR is. In the case of pregnancy, old age, there is normal immunoglobulins but increased fibrinogen, so CRP is normal, but the ESR is moderately increased. Well, that's it for ESR and CRP. Hope you find this useful. The ESRD here is actually end-stage renal disease, that is chronic kidney disease final stage. And for more medicine videos, subscribe to Ignatius Coley. Thank you.